Welcome once again to the lecture on breast cancer. And we will start with the treatment today. I'm going to repeat some slides that we did last time so that we get a complete lecture on the treatment of breast cancer. And we will have an attendance, and those who are driving during the lecture will be marked absent, all right? So let me share the screen with you. Please confirm that you can see the screen.
Yes, doctor, we can see.
All right, thank you very much. So treatment of breast cancer. Let's review the factors that affect the treatment outcomes. Okay, the ability to predict the prognosis is used to design treatment. So I mentioned a lot of factors that affect the treatment, and I'm going to repeat them once again in this slide. So our objective in breast cancer treatment, number one is, if it's an early stage, we want to cure the cancer. And with that, let us suppose it's an advanced stage like stage 4 disease, which is not curable, then at least we want to increase the duration of life or the survival of the patient. And we also want to improve the quality of life. Quality of life is very important. It's no use having a life in which the patient is bedridden or he has got severe pain or anything else that causes disability. So we have to give palliative treatment to those patients. So in order to design treatment and in order to improve the quantity and quality of life, we have to take into account certain factors, and that will help us to educate the patients as well. So age and ethnicity are important. Tumor size, we have already seen that in the stage of the cancer. Receptor expression, estrogen receptor is important for hormone therapy, and then we have seen that HER2 receptor is also very important. Then involvement of the lymph nodes, especially the axillary lymph nodes. Then if you resect the cancer, if it's small and you resect it, the surrounding tissue must be normal, which means that the status of the surgical margin that I'll show you in the next few slides, that must be negative. It should not have any cancer cells in it. Then proliferation indices, there are certain markers, certain molecules inside the cancer cells like Ki67. If they are present, that means the cancer cells divide very rapidly. Then histologic grade is very important. We have to see whether the cancer cell is well differentiated or poorly differentiated. We look at the nucleus, the mitotic figures in the cell. And that's why I said that it's important to know the pathophysiology of cancers as well. And I have a lecture on pathophysiology, but it's not a part of this course. Then we look at the nuclear grade, which is the nuclear size. So we call that nuclear to cytoplasmic ratio. The shape of the cell, the DNA content in the cell, and the invasion, lymphatic or vascular invasion of the tumor, all right? Right, so hormone receptors, they are not very important, but they do determine therapy. If estrogen receptors are positive, which are more important than the progesterone receptors, because estrogen receptors are the ones that promote cell division and cell proliferation. So if they are present, we give endocrine therapy. We look at the percentage of receptors that are present on cancer cells, right? If they are more than 1%, then we initiate endocrine therapy, which includes tamoxifen, okay? And if it is HER2 positive, there are two ways of looking at HER2. Either we look at the receptors on the cell surface, which is known as immunohistochemistry, or we can look at the gene amplification as well. So presence of HER2 receptor or overexpression of HER2 receptor, they promote cell growth and cell division, they increase tumor aggressiveness, and they have a poor prognosis, okay? And HER2 receptor has to be obtained in all cases. When the patient comes to you with breast cancer, you diagnose that. So you have to do and an evaluation of the HER2 receptors. Genetic profiling tools are important for prognostic information. We discussed two of them, and they were oncotype DXA, in which you look at 16 tumor genes, although in all there are 21 genes, but the tumor genes are 16. Then MammaPrint genetic assay, which includes about 70 genes. So all these things are used to design a treatment plan and to predict the prognosis, and also to educate the patient about his disease, or sorry, not his, her disease. All right. So the goals of the therapy depends upon the stage of the cancer. If it is an early stage cancer or locally advanced, and in that we will include stage 1, stage 2, and even stage 3, then our intent is curative. We can do surgeries. We'll come to that in a little while. But our intent, our objective is to cure the patient, to eliminate all the cancer cells. And if it is metastatic breast cancer, then we want to improve the symptoms, we want to improve the quality of life, and we want to prolong the survival or the life of the patient. So this is our drug list. I will name all the drugs because sometimes you are driving your car and listening to the lecture. When I'm actually delivering the lecture, you should not be driving. But after that, before the exams or at some time, you want to listen to the lecture. For that purpose, I'm going to name all these drugs. So that will be a good revision for you, okay? So anti-microtubular drug, which impair the functioning of the microtubules in the cells. They are eribulin, docetaxel, paclitaxel, and ixabepinolone. Alkylating agents are carboplatin and cyclophosphamide. Anthracyclines are doxorubicin and epirubicin, and let me remind you that they are cardiotoxic. These anti-microtubular drug like docetaxel, they damage the microtubules, okay? So they cause peripheral neuropathy, because microtubules are so important in the neurons for the transport of vesicles from the cell body to the terminal, axon terminal. Okay, so then we have got these calcium metabolism modifiers, which are also known as bisphosphonates, and you know that they increase the strength of the bones. And in some cases in which the cancer has metastasized to the bones and there is bone pain, these drugs can ameliorate the bone pain to some extent. And the drugs include pomedronate and zoledronic acid. Zoledronic acid is given IV. Sometimes it is given every month. Sometimes it is given every 3 months. And if you remember, in osteoporosis, this is given once in a year. Then we have got antimetabolites, capecitabine, gemcitabine, and methotrexate. We have got Vinca alkaloids. Vinorelbine is the one that we use over here. We have others, just for your revision, vinblastine and vincristine. They also affect the microtubules. They inhibit the polymerization of the microtubules. So they are also sort of anti-microtubular drugs, okay? Right, then we have got monoclonal antibodies and antibody drug conjugates. This is very important. You have to know a little bit of immunology to understand that. And I'm glad that you have already completed your microbiology courses. So trastuzumab is an antibody, monoclonal antibody that is used for HER2 receptor. Then we have got edotrastuzumab emestine, which is an antibody, a monoclonal antibody covalently linked to microtubule inhibitors, okay? So this is an antibody drug conjugate. Then we have got trastuzumab hyaluronidase. So what is hyaluronidase? It is an enzyme. What does it do? It digests hyaluronan in the extracellular matrix. So what is the effect? The effect is it will increase the subcutaneous permeability of the drug. Then we have got trastuzumab deruxtecan, in which this antibody is covalently linked to topoisomerase 1 inhibitor. We have pertuzumab, trastuzumab, both conjugated to high uranidase. Then we have got denosumab. Denosumab is actually a monoclonal antibody that increases the density of the bones, bone mineral density. We have done that in osteoporosis as well in therapy 4, all right? Then we have got pertuzumab and sacituzumab govitecan. So again, this is a drug and antibody conjugate. Lots of drugs. You have to memorize all these drugs. We are not going to go into a lot of details of these drugs. And I'm not going into the pharmacology of these drugs, although I have a lot of slides on the pharmacology of drugs that are used for breast cancer treatment, but then that will make the lecture too long. If someone is interested in that, I can post a lecture on that. You can listen to it, okay? Now, then we have got other drugs which are known as targeted therapies. Tyrosine kinase inhibitors, lapatinib, neratinib, and tucatinib. Aromatase inhibitors, they are pretty old drugs, and anastrozole, letrozole, and exemestane. I'm sure you have heard of these drugs. These cyclin-dependent kinases, CDK4 and 6 inhibitors, they are newer drugs, and they are also known as targeted therapies. And they include palbociclib and ribociclib and abemaciclib, okay? Then another new group of drugs approved in the last 3 or 4 years, PARP inhibitors. They are used in many other cancers as well in specific situations. And remember that the backbone of cancer therapy is still these chemotherapeutic agents, the cytotoxic agents. Okay, these drugs that I'm showing you over here, they have got limited applicability. So poly-ADP ribose polymerase inhibitors, it helps in DNA repair, perhaps. So olaparib and talazoparib, these are the two drugs. Then estrogen receptor antagonists, they are very well-known drugs, very commonly used in estrogen receptor positive cancers. There are tamoxifen, which is the one that is used in breast cancer. And we have got raloxifene and torimifene. Now, the problem with tamoxifen is that it is an antagonist at estrogen receptors in the breast, but it is an agonist in the endometrium. And it is an agonist in the bone as well. Being an agonist in the bone is a good thing, but being an agonist in endometrium is problematic because that could lead to endometrial cancer, but we still use this drug. Then we have got programmed cell death receptors and ligands. What do? Programmed cell death, if the receptor is activated by its ligand, it will turn off the cytotoxic and natural killer T cells. And you know, these are the T2 cells that you must have done in your immunology, the natural killer cells and the cytotoxic T cells. They attack and kill the cancer cells when the antibodies are attached there. So the PD-L1 inhibitor is atezolizumab. And then we have got PI3K inhibitors, phosphoinositide kinase, which is involved in certain intracellular cell signaling. So alpelisib is the drug. All right, so that was a quick revision. And when you are listening to the lecture, you don't have to look at the slide, which is particularly dangerous when you're driving your car. Okay, that's why I always discourage students not to drive their car when I am delivering the lecture. Okay. So what I will do here now is that I'll stop for a minute and I'll take attendance, and then we will resume the recording. Right, so treatment approaches, treatment of invasive breast cancer, we will take them up one by one, not all of them, because these are from my longer version of the lecture. But most of them we will discuss briefly in the treatment part of this lecture. So treatment of invasive breast cancer, systemic adjuvant therapy for breast cancer, treatment of carcinoma in situ, treatment of locally advanced and inflammatory breast cancer, systemic treatment of metastatic breast cancer, surgical treatment of metastatic breast cancer. Now, this might seem we have not done cancers previously, but previously we used to say that surgery has got no role in metastatic cancers because the cancers have spread to other organs like the bones or the lungs or the liver or the brain, wherever. Okay, so where do we do the surgery? And previously, people used to say that if you resect or remove the primary tumor or the primary cancer, then the secondary cancers, they start growing very rapidly, or they start growing at a fast speed. Now that myth has been dispelled now, and people have introduced a role of surgery even in metastatic cancers, which includes breast cancer as well. Okay, then we have got pharmacologic reduction and prophylactic mastectomy, and in this prophylactic mastectomy, I would like to remind you of the example of Angelina Jolie, who had those cancer genes, so she underwent bilateral mastectomy because her mother and her aunt and many women in her family had cancers, either breast cancer or ovarian cancers, right? All right, so we will start with stage 1A and 1B invasive breast cancer, in which T3, if you remember, T1, T2, T3, T4 are they represent different sizes of the cancers. Okay, T3 is more than 5 centimeters in size, and or maybe 2 to 5 centimeters in size. Okay, so and one lymph node is involved, which if a lymph node is involved, then it is stage 2 breast cancer. All right, so loco-regional therapy means local therapy in the region which is the breast and the lymph nodes. So before we go there, there are a few abbreviations. I've not given you all the abbreviations. Again, the abbreviations are given in my pathophysiology lecture or some other lecture. All right, so these are a few important abbreviations, like ALND means axillary lymph node dissection. SLN, sentinel lymph node, I'll explain to you what that is. Then IBTR, ipsilateral breast tumor recurrence. Then we have got different types of radiation therapies. Okay, so this is just for your reference. It's good if you know all of them. Surgery is considered to be primary treatment for early stage breast cancer. All right, and many patients are cured just with surgery. Now, there is a combination of surgery and chemotherapy. Sometimes you give chemotherapy before surgery, and sometimes you give it after surgery, right? And they all have their own benefits and advantages and objectives. The goal of breast cancer surgery is cure, and it includes complete resection of primary tumor with negative margins. This is a very important point to note, and I'll show this to you in the next slide, okay? Or the slide after that. So when the surgeon removes the cancer, the surrounding area, which is normal, that should also be removed with the cancer. Stage 1A, 1B, invasive breast cancer. Again, these are early stage cancers. Adjuvant therapy of breast cancer to treat micrometastasis. Now, adjuvant therapy means that the person or the doctor does the surgery, and after surgery, you give the patient chemotherapy. Which chemotherapy will you give to the patient? That I'll explain in later slides. But it depends again on the expression of the receptors, and also the dose of the therapy depends upon the aggressiveness of the cancer, right? We take into account a lot of different things. For example, cancer is a disease of old age, and in old age, many people have compromised cardiac function. And one of the important drugs that we use in breast cancer is doxorubicin. And you know that doxorubicin causes cardiotoxicity. It could lead to irreversible heart damage and heart failure. Trastuzumab also damages the heart, okay? So adjuvant therapy, the purpose of adjuvant therapy is to treat micrometastasis. Now, one thing about cancers is that the cancer cells are very loosely attached to the main tumor, and they break off and they go into the lymphatic system and they go into the bloodstream. And they are always found in the bloodstream, but cancer cells are very sort of weak and abnormal cells. They do not survive outside the main tumor. So even if thousands of cancer cells break away and they go into the bloodstream, they will die, okay? Very few of them, maybe 1 in millions or whatever, they can cause metastatic disease. And these days, one of the methods of diagnosing cancers is to find these cancer cells in the blood, okay? So the purpose of adjuvant therapy, which is therapy given after the surgery is done, is to eliminate micrometastatic cancer cells, okay? The cancer cells that might be somewhere else in the body. Adjuvant treatment for breast cancer involves radiation therapy, but remember, radiation therapy is localized therapy. If some cancers are left behind in that region where the cancer was present before you removed it, then you give radiation therapy. And systemic therapy goes everywhere in the body, okay? So systemic therapy is chemotherapy. We can use hormonal therapy, we can use biologic agents, we can use other cytotoxic drugs. Surgical treatment of invasive breast cancer may consist of lumpectomy or total mastectomy in breast cancer. In breast cancer patients who have clinically negative nodes, surgery typically includes sentinel lymph node dissection. So again, we are going to lymph nodes. Now, the problem is, what do we mean by sentinel lymph node? That I'll tell you in the next slide or after that, okay? So when you do surgery, now one of the purposes of the surgery is to preserve the breast tissue. Breast is a part of the body. If you remove breast from a woman, you have removed a part of the body of that woman. So that has got psychological ramifications, and that will have a strong effect on the woman's, on the woman's well-being, you can say, if you want. All right. So one of the main, that is why, we are doing lumpectomy. A lumpectomy means just removing that small little lump of cancer, if possible. Okay. Then post-lumpectomy radiation therapy in patients with less than 1 positive axillary lymph node. The purpose of radiation therapy after breast-conserving surgery is to eradicate local subclinical residual disease. Okay, if anything is left behind after surgery, then we give radiation therapy. Okay, now this is what I mean by lumpectomy. This is a small palpable lump. Maybe you have found this on breast examination or on mammography. So what you do is that you give a small incision and you can take a biopsy, okay, which it is known as a core needle biopsy. Or you can go deeper and you can dissect out the tumor, whatever. So this, what you have done in this type of surgery is that you have just removed this small tumor and some normal surrounding tissue. It's very important to remove normal surrounding tissue. Okay, so this is known as lumpectomy, and the benefit is you have conserved the breast. Okay, this is known as breast conservation therapy. But obviously in some cases you have to remove the breast, which is known as simple mastectomy or radical mastectomy. That I'll show you in the next slide. Okay, so this is lumpectomy. And when I said that you have to remove surrounding normal tissue, this is how it is. This is the cancer, and you have cut out some normal tissue as well, because you do not want any cancer cells to be left behind in the breast, and that is what we call the residual disease. So whenever you take out any tissue for any cancer surgery, you send it to the pathologist, and pathologist will look at the margins. Now, in this case, the margins are negative. But if you look at this one, uh, on this side of the margin, you found some cancer cells. Now, this means that some cancer cells have been left behind in the breast. And that is a little bit dangerous because they can again start growing and they can form a new cancer. So what we do about them is that we give radiation or we give chemotherapy to kill these cells, okay? Now, stage 1 and stage 1A and 2B invasive cancer. So surgery alone can cure most patients with in situ cancers and approximately 1/2 of those with stage 2 cancers. So this is, a part of the therapy. This is not the whole therapy. This therapy could be followed by chemotherapy, and sometimes it is preceded. Before doing surgery, we give chemotherapy, okay? Breast conserving therapy is appropriate primary therapy for most women with stage 1 and stage 2 disease. It is preferable to modified radical mastectomy because it produces equivalent survival rates with cosmetically superior results, right? So breast conservation is one of the objectives, and our experience shows that the results are for breast conservation therapy are as good as removing the whole breast, okay? But obviously the surgeon and the oncologist and the team that is treating the cancer, they have to evaluate the patient, okay? And just to remind you, stage 1, there is a tumor, but no lymph node is involved. And in stage 2, the lymph nodes are involved, okay? And this will be different. The staging is different in different cancers. So this is for breast cancer, right? Breast conservation therapy includes removal of part of the breast, surgical evaluation of lymph nodes, followed by radiation therapy to prevent local recurrence, okay? Now, this radiation therapy has got some side effects, which I've given over here. Radiation therapy is administered to the entire breast over 4 to 6 weeks to eradicate residual disease after breast conservation therapy. And the complications of radiation therapy are reddening and erythema and shrinkage of the total breast mass, which are tolerable, okay? It is better than removing the whole breast, at least cosmetically. And cosmetics are very important, especially for females. Now, again, we are still at stage 1, 2B cancers, and we now go on to simple or total mastectomy. It involves removal of the entire breast without dissection of underlying muscles. Now, if you remember, I said the muscle that is beneath the breast is pectoralis major muscle. And in this, sometimes you can remove the axillary lymph nodes, sometimes you don't remove them, okay? This procedure is used for carcinoma in situ, particularly ductal carcinoma in situ, where the incidence of axillary lymph node involvement is only 1%, or with local recurrence following breast conservation therapy. Okay, so I hope everything is clear so far. Then axillary lymph nodes should be sampled for staging and prognostic information. Now, what we do is when the doctor or the surgeon is performing surgery, he wants to know whether he should remove the lymph nodes or not. And he does not know which lymph, in some cases, he does not know. In some cases, we find out which lymph nodes should be removed. What we do is we inject something into the tumor tissue, the actual tumor tissue, and that thing could be traced, like we inject a radioactive material in the tumor tissue. And obviously, whatever goes into the tumor tissue will be drained through the lymphatics. So then we follow it and we see where it is going to, which lymph nodes it has gone. Okay, so that is how we find the lymph nodes where the tumor drains, where the tumor is draining primarily, if you like, okay? And so then we remove those lymph nodes, or we can further evaluate those lymph nodes for cancer cells. So lymphatic mapping, this is known as lymphatic mapping, with sentinel lymph node biopsies, less invasive alternative to axillary dissection. So one alternative is that you remove all the lymph nodes in the axilla. Now that causes problems. That can cause swelling of the whole arm, because then the lymphatic fluid from the arm will not be able to drain out of the arm. Okay, so that is why we do a procedure which is known as lymphatic mapping, and this is what it is. Okay, now this is the tumor. So what we have done is that we have injected a radioactive substance right inside the tumor mass, and then these are the lymphatics. So it will immediately, within seconds or minutes, this will drain into the lymph nodes. We can do the same procedure during surgery as well. What we do during surgery is we inject something that can be seen and that is inert, that doesn't cause any damage to the tissues. India ink is one of those things. Okay, so you see what has happened is that after injection, this radioactive substance has drained into these two lymph nodes. So with the help of a radioactive probe, you can find out exactly these two lymph nodes. And if you're doing it during surgery, you inject an ink, so you can actually eyeball, you can see that the ink is going into these lymph nodes. You have already opened up the tissue, you have given an incision, so you can remove those lymph nodes where the ink has gone. Or if it is before surgery, then you can take biopsies or you can evaluate these lymph nodes. Okay, so here they have done a lumpectomy. They have removed the lump, not the whole breast, and they have removed these two lymph nodes, which were sentinel lymph nodes, because that's where the tumor tissue was draining. Okay, those were the first lymph nodes in which the tumor tissue was draining. Right, so this is simple mastectomy. And what you do is that you remove the whole breast tissue, the areola and the ducts and everything. Yes, the alveolar tissue, the lobules of the breast, and you remove the nipple as well. And you leave behind the skin, because later on you can reconstruct the breast with some implants. So that will not look very bad cosmetically. So this is known as simple mastectomy. Evaluation of lymph nodes we have already discussed, but here are two other types of a little advanced breast cancers. This is known as locally advanced breast cancer or inflammatory breast cancer with clinically positive nodes. They should undergo core biopsy before initiating chemotherapy. Right, so core biopsy, what is core biopsy? You put in a wide needle. There are two types of needle biopsies. One is needle aspiration biopsy, in which you put in a thin needle. The problem with needle aspiration biopsy is that you don't get enough material. You might miss the cancer cells. And with the core biopsy, you have got a wider needle, so you get more cancer tissue and you can have a better diagnosis. Okay, so those with clinically negative nodes may undergo sentinel lymph node biopsy before the start of the treatment. So again, these are the sentinel lymph nodes. It should be preferable to perform sentinel node sampling upfront, because chemotherapy might eradicate pre-existing disease in sentinel lymph nodes, and you might get false negatives, right? So upfront means that before initiating any therapy, you must do a lymph node mapping. Okay, you must find out the sentinel lymph nodes. And just to remind you once again, sentinel lymph nodes are those lymph nodes where the tumor or the cancer cells drain, into which the cancer cells drain. All right. Okay, so this is total simple mastectomy. You know what you have done? You have removed the whole breast tissue. Maybe you leave behind the skin, and you sometimes remove the lymph nodes as well. Now, previously I mentioned that sometimes you give therapy before you do surgery. Sometimes you give chemotherapy after you do surgery. What chemotherapy you give, that depends. Okay, depends on the receptors, but most of the times you do add cytotoxic or cytotoxic drugs like doxorubicin or docetaxel to kill the cancer cells. So neoadjuvant therapy is given before surgery. Why do we give a therapy before surgery? Let us suppose that the cancer is very big. It is T3 or T4 more than 5 centimeters in size, right? Then what we want to do is before doing surgery, we want to reduce the size of the cancer, right? We want the cancer to shrink. Now, when the cancer shrinks, it has got certain advantages. Number one, the surgery becomes easier. Number two, you can do a breast conserving therapy, okay? Breast conserving surgery, you don't have to remove all the breast. So these are the advantages of neoadjuvant. Neoadjuvant means given before surgery. So treatment given before primary therapy, which is surgery, to shrink a tumor that is inoperable in its current state or size, so it can be surgically removed, okay? To shrink the tumor enough to allow breast conserving surgery. So these are the objectives of neoadjuvant therapy. Now, adjuvant therapy is given after surgery. You perform the surgery, you take out the cancer, but there is always a possibility that some cancer cells have been left behind in the body, which is known as residual disease, okay? So treatment given after primary therapy to increase the chances of long-term disease-free survival. What is primary therapy? Surgery like simple mastectomy, radical mastectomy, it is more extensive. You remove more tissue. Maybe you have to remove the underlying muscle as well. You remove a lot of lymph nodes, okay? Or lumpectomy, that is breast conserving surgery. So after this, we give adjuvant therapy. All right, so after about 5 or 10 minutes, we'll take a break. Systemic adjuvant therapy is the administration of systemic therapy following surgery, radiation, or both to treat micrometastatic disease. That is one purpose. And the second purpose is to prevent recurrence. If you leave some cancer cells in the body, they can grow and they can recur. So the goal is to eliminate them. And that is the purpose over there, okay? What chemotherapy, you can give endocrine therapy or as I said, cytotoxic drugs, or both they both result in improved disease-free survival. Disease-free survival means, patients can survive with their disease as well, but disease-free means no disease at all. Overall survival means how long will they live? So they will live longer. That has been seen with these therapies. The National Comprehensive Cancer Network practice guidelines are updated. I showed them to you in the first few slides. So when you go to your oncology clinics, you may want to refer to them. And the addition of hormonal therapy in all women with receptor positive disease, whether it is estrogen receptor positive or HER2 receptor positive, to this chemotherapy, which includes docetaxel, or it could include doxorubicin, cyclophosphamide. We have got many different protocols for breast cancers, okay? Right, so stage 1A and 2B, now we are going to invasive breast cancer early stage neoadjuvant therapy. The goal is to cure the patient, prevent recurrences, and eradicate the micrometastatic disease. Chemotherapy is the gold standard, right? I've shown you those 2 slides with maybe 40, 50 drugs, but the gold standard is still chemotherapy. Hormone therapy can be considered in hormone receptor positive or in postmenopausal women. Trastuzumab plus minus pertuzumab, these are both antagonists, or these are both blockers of the HER2 receptors. So these drugs containing regimen should be considered for HER2 positive patients. Appropriate therapies include endocrine therapy, chemotherapy, HER2 directed therapy, and bisphosphonates. Now, bisphosphonates do not affect the cancer cells. They just increase the bone mass density. When the cancer metastasizes to the bone, then you give these bisphosphonates. They reduce bone pains. All right. Okay. Stage still 1A to B invasive. Now we look at endocrine therapy. Not much to look at it, but we have to test for estrogen and progesterone receptors. ER and PR status, estrogen progesterone receptor status, should be determined by immunohistochemistry. The pathologist will do it for you. And you have to do it on all cancers. You also have to look for HER2 receptors. Now, if the percentage of these receptors is more than 1%, consider endocrine therapy in patients whose breast tumors are more than 1%. Okay. If they are less than 1%, you don't use endocrine therapy, because obviously every therapy has got its side effect. Patients with higher hormone receptors. Now, if the patient has got a lot of hormone receptors, 3%, 4%, 5%, more than that, then the response to the therapy will be even better, right? Then the outcome is going to be much, much better. So more estrogen receptors, although more estrogen receptors, if you don't treat them, the cancer will grow very, very fast. But if you treat them with these drugs, we have got so many drugs. I mentioned tamoxifen, we have got aromatase inhibitors as well. Then you will see a dramatic improvement in the cancer. All right. So I think we will stop here and we'll take a 15 minutes break. So I'm going to pause the recording for some time. And when we come back, please remind me to resume the recording. So in this slide, I'll show you what I mean by invasive ductal carcinoma. You have already seen that we have invasive stage 1, stage 2B, and all those cancers. Now, how does the cancer start? You know, this initially we discussed and we mentioned that the cancer either arises in the lobules, which are the milk-producing glands in the breast, or they arise in the ducts. Okay, so these are known as the ductal carcinomas, and these are known as the lobular carcinomas. So this is a duct. This is a blown-out view of a duct, which I've shown you over here, milk duct, all right? And these are the cells. These are the epithelial cells, okay? And the cancers arise from the epithelial cells. Now, here are the cancer cells. These blue cells are the cancer cells. Now, what you see over here is that these cancer cells are inside the duct. Beneath these epithelial cells, there is a layer of basement membrane. Now, these cancer cells, they have not invaded the basement membrane. Okay, they are inside the duct. So the most important thing to remember is that these cells have not invaded the basement membrane. And when they have not invaded the basement membrane, we call it ductal carcinoma in situ. Okay, when they invade the basement membrane, like I've shown you in this diagram, you see they have gone through the basement membrane into the surrounding tissue. We call it invasive ductal carcinoma. So carcinoma in situ, not invaded the basement membrane, and invasive carcinoma, it has gone through, it has invaded the basement membrane. All right. So here we are going to look at the treatment of carcinoma in situ. First, we will look at ductal carcinoma in situ. Currently, the standard treatment of ductal carcinoma in situ is surgical resection with or without radiation. Now, you can imagine that it's inside the duct, so it is a very small cancer. Okay, so the treatment of choice over here is surgery, and obviously it is going to be a lumpectomy because it is a very small cancer. Adjuvant radiation and hormonal therapies are often reserved for younger women, patients undergoing lumpectomy, or those with comedo subtype. We didn't go into these subtypes of cancers, but comedo subtype means an aggressive subtype of breast cancer. Okay, I think I've written it over here. So it has got greater malignant potential. So, you know, we do surgery, or before surgery, we can give radiation or hormonal therapy to try to eradicate the cancer cells, right? Tamoxifen is the only hormonal therapy approved for adjuvant therapy in patients with breast conserving surgery and radiation for ductal carcinoma in situ, right? So tamoxifen is the drug. It could be given for 5 years. It could be given for 10 years after surgery. And then the other option is radiation therapy. Now, adjuvant tamoxifen also reduces the risk of contralateral breast cancer. If you remember in the beginning, I showed you the lymph nodes, the mediastinal lymph nodes on both sides, the right side and the left side, they have connections with each other. So if the cancer cells go into the mediastinal lymph nodes, they can go to the other breast, okay, which is known as the contralateral breast. So lobular carcinoma in situ. This is less aggressive. This does not, mostly it does not invade the basement membrane. Okay. Overall treatment options for lobular carcinoma in situ include observation and close follow-up. That is the most common thing we do. Or, if you think, if you have taken a biopsy, and if you find that the cells are poorly differentiated and you see the nuclei, they have got very big nuclei, and nuclear to cytoplasmic ratio is not favorable, and there are lots of mitotic figures, which in simple word means it's a very aggressive cancer. If it is aggressive, then you can do, give tamoxifen, or you can even do a bilateral mastectomy, but that is a decision that will be made after thorough evaluation that will be done by the whole team that is treating the patient only. Now, treatment of carcinoma in situ, non-invasive breast cancer, local management. There are no survival differences between the following 3 approaches: breast conserving surgery, which is also known as lumpectomy plus radiation therapy, or total mastectomy with reconstruction, simple mastectomy with reconstruction, or breast conservation therapy without radiation. So with radiation, without radiation, lumpectomy, breast conservation, or mastectomy, total mastectomy, you have got so many options, okay? Endocrine therapy, it is not recommended by guidelines in hormone receptor negative ductal carcinoma in situ. Hormone receptor negative means no estrogen receptors, no progesterone receptors, and no HER2 receptors. That is also known as triple negative, which is a very dangerous form of cancer. Patient with ER positive ductal carcinoma in situ with breast conservation surgery, you can consider endocrine therapy for 5 years. Okay, so tamoxifen for 5 years. Tamoxifen is an option for pre or post-menopausal women. But if you have to give treatment to post-menopausal women, you can also use aromatase inhibitors that I'll show you in the next slide. Okay. So tamoxifen, both for pre-menopausal, post-menopausal, and aromatase inhibitor for can also be used for post-menopausal women, particularly those with risk of thromboembolism. Okay. So tamoxifen, in certain instances, tamoxifen is also estrogen agonist. And estrogen predispose the patients to a risk of developing clots in the blood, which is known as thromboembolism. If you remember, you have done oral contraceptives in therapy 4. Oral contraceptives also increase the risk of thromboembolism because they contain estrogens and progesterones both. Okay, right. So treatment of locally advanced breast cancer. A locally advanced disease includes patients who are technically operable, but who have large primary tumors more than 5 centimeters in size. The reason for using neoadjuvant therapy in women with large primary tumors is to increase the possibility of breast conserving surgery, right? So what you do is, if you find with your mammogram or with your MRI, CT scan that the tumor size is very big, you give neoadjuvant therapy to reduce the size of the tumor. In 2013, FDA approved pertuzumab for neoadjuvant treatment with trastuzumab and docetaxel for patients with HER2 positive, locally advanced or inflammatory or early stage breast cancer, either greater than 2 centimeter in diameter. Although 2 centimeters is not very big, but even if you reduce the size from 2 centimeter, the surgery will become easy. You know, bigger, removing larger tissue from the body means more damage to the tissues. So it's always good to do a minimally invasive surgery, or remove the least amount of tissue, you know. So that is why in these cases, neoadjuvant therapy is administered. These tumors are more likely to stain negatively by immunohistochemistry for estrogen receptor and progesterone receptor, and they are more likely to be positive for HER2 overexpression. Now, if you remember from the initial histologic classification that I showed you, luminal A, luminal B, triple negative, and the fourth type was ER/PR negative and HER2 positive. Okay, they are very most aggressive cancers. So if in these situations, we might expect these aggressive cancers. Okay, the situations that I've shown you over here. Right, inflammatory breast cancer, again, you know, it has got signs and symptoms of inflammation. That is why they are known as inflammatory breast cancer. It is a clinical diagnosis that implies presentation of cardinal signs of inflammation, warmth, redness. It includes warmth, redness, pain, and swelling as well. But here, you know, redness, you know, warmth may not be there involving breast, although the warmth may be subtle and the mass may not be appreciated as something discrete, but, you know, still the skin will be red. Okay, so that's why you call it inflammatory breast cancer. In Western countries, the frequency of inflammatory breast cancer is low, 1 to 2%, but in certain ethnicities, like North Africa, in Northern Africa, it is much higher for reasons that we are not sure about. These tumors are more likely to stain negatively by immunohistochemistry for estrogen receptor and progesterone receptor, and they are more likely to be positive for HER2 receptor. So they are aggressive cancers. Locally advanced breast cancer is associated with lower socioeconomic class and with Black race in the United States. It's a bit unfortunate. In most case series, locally advanced breast cancer has better long-term outcome than inflammatory breast cancer. Okay, so at least they are better than inflammatory breast cancers. All right, so now we go on to the metastatic breast cancer, and we are also coming to the last part of this lecture. Systemic therapy must be instituted for recurrent or metastatic breast cancer so that the drug reaches all sites. Now, metastasis means that the cancer has gone into the bones from the breast. It has gone, maybe it has gone to the lungs, maybe it has gone to the liver, maybe it has gone to the brain, right? So we have to give a sort of treatment, a type of treatment that must reach every tissue in the body, and the only possible way to do that is to give it into the bloodstream. Okay, because the blood goes everywhere. So we give systemic therapy. Systemic therapy means giving therapy in the bloodstream. So despite advances in the treatment of early stage breast cancer, many women still develop recurrences and metastasis. And that's the problem with all the cancers. You know, they return, they come back, or they can become metastatic at some stage later in the life. In 5 to 10%, you know, at the time of diagnosis, the patients already have metastatic disease. But fortunately, it's not a high percentage, it's just 5 to 10%, which means 90 to 95% of the women, they do not have metastatic disease at presentation. And that is one of the reasons that the guidelines recommend screening after a certain age, okay, by the age of 50 years. If the patient is high risk, like if the BRCA genes are mutated or there is a mutated P53 gene, then screening should be initiated at an early age, like at the age of 40 years, okay? So the purpose of doing screening is to diagnose the cancer early before it has metastasized. Despite improvement in treatment of metastatic breast cancer, there remains no cure once distant metastases have developed. There are two main interventions. One is hormone therapy and the other is chemotherapy. But usually in metastatic disease, most of the people, they recommend hormone therapy only to begin with. Now, there is another thing, there might be different protocols in different places in different countries. I can give you the list of protocols, but you don't have to memorize all those protocols, okay? I'll give you some common ones. I didn't give them in this lecture because this was a short lecture. I'll just mention a few drugs in some specific situations. I've already mentioned that if it is hormone receptor positive, you have to give hormone therapy, which consists of tamoxifen and aromatase inhibitors. Chemotherapy, I've mentioned a few drugs, and I've given the list of drugs in the drug list as well, okay? So you have to at least memorize the drug lists. Now, hormone therapy in estrogen receptor positive or progesterone receptor positive metastatic breast cancer, the American Society of Clinical Oncology recommends using endocrine therapy rather than chemotherapy as the first line treatment. So you have to use one, because if you use both, you will not know which one is working. Chemotherapy will always work because it kills the cancer cells. But what you want to do is that, if the cancer has gone to other tissue, now our objective is to improve the quality of life and to increase the overall survival of the patient, right? So we want to keep some drugs in reserve so that we use them when the cancer progresses. That is why, if it is estrogen receptor positive, we should first start with endocrine therapy, and we will keep giving endocrine or continue with endocrine therapy as long as it works. As soon as the tumor progresses, then we can start with chemotherapy. A trial of hormone manipulation alone can assess whether hormone therapy is effective, which is impossible to determine if you give it with cytotoxic chemotherapy, right? So that is why the first line therapy in metastatic cancer, which is hormone receptor positive, you start with hormone therapy. In a randomized study, it was found that combination treatment with anastrozole and fulvestrant, which are aromatase inhibitors, you see, combination therapy, giving these two drugs together, it is superior to giving either of them alone or giving them in sequence. Okay, sequential therapy means you first give anastrozole for a certain period of time, a few months, then you stop anastrozole and give fulvestrant, right? But what they found is that if you give them together, it was better than sequential therapy, and it was also better than using either of these drugs alone as monotherapy. Now, again, I've written this is for reference only, but there are certain things that you have to memorize for the examinations. All right, so check once again. I'm going to remove some reference only. When I write for reference only, that means I'll not include this slide in the examination, but I'm going to remove some this logo from some of the slides, okay? So in postmenopausal women and premenopausal women, more or less, we have got the same treatment. These are, this is estrogen receptor antagonist, tamoxifen, then aromatase inhibitors, anastrozole, letrozole, and exemestane. This is also, fulvestrant is also an estrogen receptor antagonist, okay? In premenopausal, more or less the same thing. The only thing that we are adding over here is gonadotropin releasing hormone agonist, also known as luteinizing hormone releasing hormone, okay? Leuprolide and goserelin. I hope you have done that in your pharmacology for anti-cancer drugs. Megestrol not very commonly used, but it is one of the options. So in chemotherapy, when the patient has life-threatening disease or severe symptoms that require quick relief, combination of cytotoxic agents may be preferable because of their high response rate and early onset of clinical benefit. So, these chemotherapeutic drugs, these cytotoxic drugs, they have got a lot of side effects, and these drugs, they destroy the normal cells as well. And they have got very narrow therapeutic indices. So a little bit of overdose, they are going to have severe toxic effects, but they are very rapidly acting. They're still the backbone of cancer treatments. It is either surgery in the early stages or in the late stages. We supplement surgery with chemotherapy. Okay. So in life-threatening disease, or when the patient has got severe symptoms, then we use chemotherapy. And in the setting of advanced disease, the goal in determining treatment regimen should be to prolong survival and maintaining a good quality of life. So remember these primary objectives in cancer chemotherapy. You must maintain the patient's quality of life. And quality of life, if the quality of life is good, you can sometimes give higher doses of the drugs, even these chemotherapeutic drugs, okay? And obviously you want to improve the survival of the patient as well. It is known as prolonged survival, is also known as overall survival, OS, okay? A second situation which is becoming increasingly common is when cytotoxic chemotherapeutic agent is combined with a targeted agent. Now in the drug list, I showed you so many targeted agents. Some of them I'm going to show you once again. Other than hormone therapy, okay? These targeted agents often have very low, that's the problem, They are there, they are very expensive, but they have got very limited use. They are used in very specific situations. For example, some of them will be used when there is a mutation of the BRCA gene, all right? And now, one more important thing about cancers, about chemotherapy. It is important to realize that if 1 year or more has elapsed since completion of adjuvant therapy, you give certain cycles, you give 6 cycles, 8 cycles of whatever protocol you're using, then you stop the therapy. If the patient remains disease-free for 1 year or more, that is a good thing, And, let us suppose that the cancer comes back, it's diagnosed again after 1 year. Then you can give the therapy that you had given previously. Okay, a patient's tumor is likely to respond to previous given drug or combination as though that drug or combination had never been given, right? So remember, what I'm saying over here is that if the cancer recurs, you give treatment, you give whatever the number of cycles are of the chemotherapy, and the patient doesn't have any problem for 1 year. But the disease, the cancer comes back after 1 year or 1.5 years, then you can use the same therapy. Okay, it means that although we give the therapy, when the cancer is growing, because the cancer has got a poor blood supply, and blood supply is needed for multiplication of cells because the cells need oxygen, they need nutrients, they need glucose, they need to make ATP for cell division. So the blood supply of cancers is very bad. The cancer is not a normal tissue. It is a very poorly developed tissue, and it has got poorly developed blood vessels. So the blood supply of cancer is very bad, which means the cells that are deep within the cancer, when the cancer size increases, those cells will not get a good blood supply. Okay, so those cells will not divide. So when you give chemotherapy, it's only the dividing cells that are dying. Those cells that are not dying, they will remain inside the body. Although you're giving 6 cycles or 8 cycles, some cells might not be there. And then after 1 year or 1.5 years, they will start dividing again and the cancer will recur. So you can give the same therapy. But if it recurs in less than 1 year, although taxanes are not If the disease recurs in less than 1 year, then you have to change your therapy. All right. Now, taxanes, what are taxanes? Docetaxel, very commonly used. Paclitaxel is also one of the taxanes, okay? They are not cardiotoxic. Doxorubicin is cardiotoxic. Trastuzumab is cardiotoxic, okay? But they cause neuropathy, lingering, or, that goes on for a long time, peripheral neuropathy, especially paclitaxel, or problems with edema, especially docetaxel, which makes further administration problematic. Okay, so I just mentioned a little while ago in this lecture that they are anti-microtubular drugs. They damage the microtubules, and in the nerves, microtubules play a very important role in transport of vesicles. So if you damage the microtubules, the nerves will be damaged. If tumor has recurred quickly after administration of adjuvant chemotherapy containing a taxane, then changing the schedule of administration can be effective. So if the tumor recurs after 1 year, you give the same therapy. If the tumor comes back before 1 year, you have to change the therapy. Drugs such as capecitabine. Capecitabine is an oral drug. You did in your pharmacology that most of these drugs are given intravenously, these chemotherapeutic drugs. But capecitabine is given orally inside the body. It's a sort of a prodrug inside the body. It is converted to 5-fluorouracil, okay? Now, this has got very little myelosuppressive potential. Myelosuppression means suppression of the bone marrow. So when the bone marrow is suppressed, what will happen? The patient will get anemia. The patient will get a low number of white blood cells. Okay, that will predispose him to infections. So that is a big problem in cancer chemotherapy. So capecitabine, little myelosuppression, they are often chosen when patient's bone marrow has been damaged, or you are giving a drug that is highly myelosuppressive, co-administer a myelosuppressive agent. So you give capecitabine in combination. We have got another anti-metabolite, which is gemcitabine. It is typically given in combination with paclitaxel in locally advanced breast cancer and also in metastatic breast cancer. Vinorelbine is a Vinca alkaloid. Whenever you have got this VIN, Vinca, it is a Vinca alkaloid like vinblastine, vincristine, okay? So vinorelbine is often used as a single agent following treatment with a taxane, or this is a taxane, or an anthracycline. Anthracycline is idarubicin or doxorubicin, daunorubicin, so many of them, or 4 or 5 of them. Then you have got, this targeted therapy, palbociclib. It is an inhibitor of cyclin-dependent kinases, and it is used for first-line treatment for ER-positive, HER2-negative metastatic breast cancer in post-menopausal women in combination with aromatase inhibitor letrozole. So see, so many conditions. It is used in combination with letrozole. It has the ER receptor has to be positive, and it is used in post-menopausal women. And the outcome of these targeted therapies is not very good. It is not as good as the cytotoxic drugs. Another new group of drugs which are known as PARP inhibitors, poly-ADP ribose polymerase inhibitors, okay? This enzyme, it helps in DNA repair. In January 2018, FDA expanded approval of olaparib to be included in treatment of BRCA-mutated HER2-negative metastatic breast cancer in patients who have been previously treated with chemotherapy. All right, so again, this is used in a specific situation when the BRCA gene is mutated. Olaparib is the first drug of any kind approved to treat certain patients with BRCA-mutated metastatic cancers. We have another one as well, which is talazoparib, another PARP inhibitor. It was approved for patients with deleterious or suspected deleterious germline BRCA mutations in HER2 negative patients. Okay, so again, very specific situations and very expensive drugs. Now, trastuzumab, it is known as Herceptin. That's the brand name. It is used in patients with breast cancer or expression of HER2 receptor. Administered concurrently with non-anthracycline. Anthracyclines are doxorubicin and ivorubicin, and they are cardiotoxic. And this drug is also cardiotoxic. So it is not combined with anthracyclines, okay? It stands for, HER2 stands for human epidermal growth factor receptor 2. And Herceptin intercepts extracellular domain. So this is the HER2 receptor. This is a cancer cell, okay? This is the cell membrane. And these are the HER2 receptors, which are growth factor receptors. So they will lead to cell division and proliferation of cells. When you block them with these antibodies, which is trastuzumab, their downstream signaling will be blocked. And they will also be labeled for attack by macrophages or cytotoxic T cells or natural killer T cells, okay? So Hercept2 has a tyrosine kinase activity, cell biology, something that happens inside the cells. Mechanism of action, by binding to HER2, it blocks the downstream signaling pathway of HER2 receptor, and the downstream signaling promotes growth and cell division. So if these antibodies are not there, the cell will divide. These antibodies stop the cell division. Adverse effects, congestive heart failure. This toxicity worsens with doxorubicin, so the combination is not used. Extreme caution needed with pre-existing cardiac dysfunction. It's already an old woman who has got some compromised cardiac function, then you have to be very careful. Then it could have infusion reactions, and that is a problem with many of these monoclonal antibodies. Hypotension could be there, okay? So that should also be taken into account. And the cost of the therapy is $140,000 per year. See, very expensive treatment. Now we go on to triple negative metastatic breast cancer. I think just a few slides left now. Unresectable, which means you cannot operate upon them. Unresectable metastatic triple negative breast cancer, which are estrogen receptor negative, progesterone receptor negative, and HER2 receptor negative. They are very aggressive cancers. All these estrogen and HER2, they cause cell division. And if the receptors are not there and the cell is still dividing, that means that the cell is very, very aggressive, because it can divide without any signal from outside. Without these receptors, it is dividing. So that is a very aggressive cancer, and the prognosis is pretty poor. Combination therapy with programmed cell death ligand, atezolizumab, plus nanoparticle albumin-bound paclitaxel has been shown to prolong this progression-free survival, right? But unfortunately, this FDA issued an alert that atezolizumab plus paclitaxel is ineffective in previously untreated patients, right? So you must try to treat the patients with other drugs first. And if that treatment fails, then maybe it is the decision of the oncologist whether to use this drug or not. Now, in April 2020, the FDA granted accelerated approval to first antibody drug conjugate, which is sacituzumab and govitecan. And this is a biosimilar for metastatic triple negative breast cancer in patients who have received at least 2 prior therapies for metastatic disease, right? So you have to try other therapies first. If you fail, then in the end, you can use these therapies, okay? So this sacituzumab, govitecan, that has now been approved. And I think this is the last slide of the lecture, anti-angiogenic therapy. We have a drug which is known as bevacizumab, and this drug inhibits the growth of blood vessels. Angiogenesis is recognized as a key process in progression and metastasis of breast cancer. Now, I already explained to you that blood supply to the cancer is very important, but it's very poor. All tumors have got a poor blood supply. That is why when the cancer size grows, some cancer cells deep inside the cancer, they start dying, you get necrosis, or some of them stop, they don't die, they just stop dividing, which is not a good thing, okay? So this is an antibody against vascular endothelial growth factor, VEGF. The brand name is Avastin. It is a humanized monoclonal antibody directed against vascular endothelial growth factor, which exerts an independent effect on the process of new blood vessel formation. But unfortunately, in breast cancer, again, the FDA withdrew its recommendation in 2011. Bevacizumab was approved by FDA as first-line therapy for HER2-negative metastatic breast cancers. However, in November 2011, FDA officially rescinded its approval of bevacizumab because the drug had not been shown to be safe and effective for this use in breast cancers. Adverse effects are GI perforations, stroke, wound healing complications. You know, for wound healing, you need growth of blood vessels, organ damage, and neurological complications, okay? And that is all about this lecture. After this lecture, we are going to start with lung cancer lecture, so please don't go away. And if you have any questions, you can ask me now. And if you don't have any questions, I'll stop the recording.